वो नीचे वाला और
Good evening, everyone. I welcome you all to this exciting session on IAPS NEXTGEN, Radiology in Pediatric Urology. Our speaker for today is Dr. Vikesh Agarwal sir, a distinguished figure in the field of pediatric surgery who currently serves as the professor and head of Department of Pediatric Surgery at Netaji Subhash Chandra Bose Medical College, Jabalpur. Professor Vikesh sir has made remarkable contributions to pediatric surgical practice, education, and research with over 120 publications to his name. He has served as Secretary General of IAPS. Sir also plays a vital role in academic publishing as the executive editor of the Journal of Indian Association of Pediatric Surgeons. His dedication to knowledge dissemination is extraordinary, and we are truly honored to have him with us today. And we look forward to benefiting from his insights and experience on this very valuable topic. Over to you, sir.
Thank you very much. Thank you, Padma, for a very nice and kind introduction. I thank the current president, Dr. Miglani and Dr. Arvind Sinha, sir, for giving me this opportunity. Are you able to see my slides? Are you able to see? Yeah, okay.
Yes, sir, we are able to see your slides.
And slide is moving also?
Yes, sir, they are moving.
Okay. So basically, I'll begin my presentation as I prepared this talk for mostly postgraduates. So first, it will be like little bit basics about imaging in pediatric urology. And then gradually I'll touch upon various conditions of pediatric urology, which we commonly encounter as well as we rarely encounter. Coming to the first thing, the most useful investigation which we have in our hand is ultrasound. So there are three basically terminologies which we use in imaging. One is echogenicity, second is intensity, and third is density. So echogenicity is the word used for ultrasound, while density is the word used for CT scan, and intensity is the word used for MRI. So whenever we describe any imaging film, then we should use proper terminologies. So for ultrasound, we all know the echogenicity word is used, and now based on the appearance, what we get on ultrasound, there can be three types of echogenicity. One is anechoic or hypoechoic, which appears black on ultrasound. It can be hypoechoic or isoechoic, and at times it is hyperechoic, which appears white on ultrasound. Apart from that, if you see, all anechoic structures are fluid-filled structures like urinary bladder, gallbladder, or dilated renal pelvis in PUJ obstruction, while blood vessels also appear anechoic. While tumor, lymph node, all these structures or any mass lesion, they appear hypoechoic, and the echogenicity is always compared when we call hypoechoic, we always compare with the echogenicity of the liver. Then about fat tissue, it is usually hyperechoic, and stone is hyperechoic, or any calcific shadow inside the body, it appears hyperechoic with a typical post-acoustic shadowing like you see in the sixth picture. So this is post-acoustic shadowing which you see behind any calcific object. So there is a gallbladder stone here which is giving a post-acoustic shadowing and a linear hyperechoic shadow here. Coming to this next picture, can anyone tell what is this picture? You are free to talk, you are free to write. I have opened my chat box also. I can see all the chats coming here. Anyone who can guess what is this picture showing? It's an ultrasound picture. As you can see, A lines. Someone is calling A lines, thorax ultrasound. Karthik is putting a question mark. So it's an artifact. It's a guess. Now tell me. It's a hint. Now you tell me. It's an artifact you see on ultrasound. Something you see on thoracic ultrasound very commonly.
Hello.
Yeah. This is called as reverberation. So it's an artifact. Reverberation is an artifact in ultrasound, which is an image error, which is caused by sound waves bouncing back and forth between two strong parallel reflector. For example, if you do a chest ultrasound, so two ribs are there, or the chest wall is there, then fluid is there, then lung is there, then pleura is there, then lung is there, which is filled with air. So there are multiple layers of varied ecogenicity structures which result into this reverberation artifact. It should never be confused with the post-acoustic shadowing. That is the point I wanted to make using this slide. Coming to computed tomography, that we commonly call as CT scan. So in CT scan, can anyone tell what does this slice means? Slice, what is the meaning of slice? Can anyone open the mic and tell me what is the slice? What is the meaning of the slice? We have commonly used this word. 64 slice CT scan, 128 slice CT scan. Okay, I'll tell you simply. Now there are two things in computed tomography. One is the collimator through which the X-rays are coming. So it is based on X-ray principle only. So X-rays are coming through the collimator, and there is something called as detector. So detector and collimator. So whenever you have single collimator and single detector, then it is called a single slice CT scan, which is nowadays obsolete. If you have like more than one detector, for example, if you have 16 detectors, then it is called as multi-slice CT scan or 16-slice CT scan. What is the purpose? It allows multiple sections at the same time, so increase the speed of the CT scan, and it allows faster rotation, and it has better speed and resolution than a single slide CT scan, and it gives thinner slides. Like sometimes we go for HRCT. So these are the places where we use higher slice CT scan. So like if you see some organ which is having quick movement, for example, heart, there you cannot use 4 or 16 slice CT scan. You need a very high number of slices in the CT scan. For example, 320 slice CT scan to do cardiac angiography. But nowadays, most of the places we have 64 slice CT scan, which is called as workhorse CT scan. So it gives you good balance, good speed, good detail, and at the same time we don't want to radiate the child so much, and we want to restrict the radiation also. So this is the concept about slice. Now coming to dual source CT scan. Anyone knows dual source CT scan? What is dual source and what is the utility of dual source? So normally in all CT scan which we use, we have single source CT scan. That collimator is only one. So whenever you have two collimators, so you use two energy levels for material differentiation. So normally what you do, like with one, it delivers different kV of radiation. So through one collimator, a different kV is delivered. Through other collimator, different kV is delivered. So that allows you to differentiate two different radio opaque objects, and it is most commonly used in urology for identification of the content of the stone, because various stones, they have different characteristics on CT scan. It is important when you go for non-invasive treatment. I will tell you later. So dual source CT scan has restricted use in pediatric imaging except for one condition, which is renal stone. Coming to contrast agent, we all know about contrast agent. Just a quick word about it to complete my presentation. In ultrasound, we use microbubble agents, which is not very commonly used because it has not stood into the test of time providing accurate knowledge. But CT scan contrast, we should all know about types of contrast, and in MRI, we use gadolinium-based agents. We all know MRI has no ionizing radiation, while CT is based on X-ray principles, so it has ionizing radiation. So we all know the differences between CT scan and MRI. CT gives good anatomical detail, gives high spatial resolution, while MRI is better in anatomical as well as functional information. And it is good when you don't want to use, especially in children, you don't want to radiate the child. So it is a very useful investigation, especially in congenital anomalies, complex urological anomalies. Coming to CT contrast agents, there are two things important to remember. One is ionicity of the contrast, and other is contrast is monomer or dimer. So whenever you see an ionic contrast, for example, you have this urographin or diatrizoate. So it is usually hyperosmolar and it causes a lot of allergic reactions. So nowadays these contrasts are given up in clinical practice, and what we use nowadays is non-ionic contrast. So most commonly used now non-ionic contrast nowadays is iopomerol, which is not mentioned here, but there are various other examples mentioned here because it has lower osmolality and improved hydrophilicity, less allergic reactions. But there is one more category which is called as dimer. So it is slightly expensive contrast, which is not very commonly used, but it has osmolality equal to blood and it gives better delineation because the dimer is there. So because of dimer, so appearance is more whiter and the contrast gives better delineation of the organs. But most commonly used workhorse contrast in our clinical practice is non-ionic monomer, which is iopomerol. So coming to basic principle of MRI. Is there anyone who can explain this figure and know the basic principle of MRI in few lines? In few key lines, can anyone explain? I am there to explain if you don't say, but I will be very happy if you guys also talk. Okay, MRI principle is based on putting the body in the electromagnetic field. So alignment of the electrons or something else, not electrons. Nuclear magnetic resonance. So it is basically our bodies consist of water, hydrogen. Yeah, right. So hydrogen, it's all about hydrogen ion. So whenever you do MRI, you have to think about hydrogen content of the body. So body has hydrogen H2O molecule and inside there is hydrogen nucleus, that is one proton. So what happens in the figure B you see, in our body, the protons lie like this, like they lie haphazard. Like if you see in the school, before the assembly, all children are like talking to each other. And they are not aligned. They are not in a row, or not in a queue, not in a line. So they are just haphazard lying everywhere. But the moment principal comes in the school, what happens? They align themselves in a row or queue or line. So this is known as alignment of the protons under the magnetic field. It's a strong magnetic field which allows hydrogen ions or protons to align themselves. So after this alignment has happened, then we turn on the radio frequency pulse. So what happens? This radio frequency pulse unpair the protons, few of the protons, and they rotate them out of the alignment. So now the few of the protons have taken some energy from radio frequency pulse and they've rotated themselves. Now what will happen? Now we'll remove the radio frequency pulse. After removing the radio frequency pulse, those protons, they are already there in the electromagnetic field, strong electromagnetic field. The principal is standing there. So they will again align themselves as they aligned after the principal appeared, that the electromagnetic field appeared. But while doing so, they acquired some energy from radio frequency pulse, which is getting liberated, released. And that energy acquired or acquisition is done in the form of an image. So this is the principle of MRI. It is important to understand this principle. Why? Because if we know the hydrogen content of the tissue, we can understand what type of image it is going to produce. Coming to how the images are produced. So there is a lot of complexity in types of sequences, but I will try to simplify it. And there are two types of appearances or sequences which we commonly use. One is T1 weighted image and other is T2 weighted image. So I won't go into detail what is T1 weighted, what is T2 weighted, but it's basically, it has relation with the duration of the alignment and duration of the de-alignment. So anything which is, so first we acquire T1 weighted image, then T2 weighted image. So anything which is having less water content will appear better in T1, and having something which is having more water content will appear in T2 weighted image. So if you see this image, so T1, now easy to remember. What is T1? Only one structure appears bright. That is fat. Okay, I use urology examples in this table. So you can see only one structure appearing white in T1. What is that? That is fat. While in T2, two structures appear white. What? One is fat, another is fluid. Fluid is for sure, but fat appears less bright than T1. But if you attenuate the fat, it's known as fat suppressed image, then it appears black. So most often we get films from the radiologist, they give us fat suppressed images. So in T1, fat appears bright, while in T2, fat appears either black, or if it is not fat suppressed image, then it does appear white, but it is less bright than T1 image. While in T1, fluid appears black, in T2, fluid appears bright. That is hyperintense. So here we are using the term intense, like I mentioned before. So this much at least you should remember. Rest all structures, the appearance, they vary with the content of the tissue. If the tissue is more fluid content, then may appear more intense on T2. If it is less fluid content, then they may more fat content. For example, teratoma is there, then you will be able to see fat on the T1 image. Now, try to, understand this picture. What is this? What is A and what is B? What is A and what is B? I'm looking for answers in the chat box. If you want to speak, you can speak also. So which one is T1 and which one is T2? So Ashwin told me that A is T1, right? And B is T2. Why? T1, it is the image of the bladder. So there is fluid inside the bladder. So in T1, bladder is appearing black. Why? Because it is a T1 weighted image. And in T2, it is appearing hyperintense, white. Because fluid appears white in T2, more protons are there. It takes more time to align and de-align. That is the relation. So that is how we can understand. So this is T1, T2. So in short, I always call it that T1 is fat happy and T2 is water happy. So in T1, fat appears hyperintense or white. In T2, water appears hyperintense or white. Now look at this image. This is a picture of the kidney with hydronephrosis. Can anyone tell what are these arrows marking towards? Again, it is T1 and T2. Now try to interpret. Suppose I tell A is T1. Then what is this white structure? What is this white structure? What is this black structure? Very easy to understand. Just apply basic principles I told just now. It is T1. Yeah. Anyone want to speak? Please speak. I'm looking at the chat box also. No one? T1 is perinephric fat, not perinephric, but it is peripelvic fat. Peripelvic fat. So this is T1 image. So if you see, this is fat because it is T1. So fat is appearing hyperintense. While behind the fat, you can see the black shadow. That is hypointense. That is dilated pelvis in a case of PUJ obstruction. While in the T2 image, if you see, it is reversed. It is a fat suppression image. Fat suppression image, so fat has become black. Okay, and the pelvis is appearing bright. It is hyperintense because it is containing fluid. So this is so simple to understand. Now tell me, what is this? Two yellow circles. What are these structures? Can anyone tell? If you have seen my slide, comparison of T1, T2, how they appear, then you can answer this question. What are these yellow arrows? Anyone? Blood vessel. Very good. Why? Because blood vessel has a moving fluid. It is fluid, but it is a moving fluid. So what happens? Even with high electromagnetic field, they don't align because there is a movement. Already the energy is there in the blood cells and the fluid which is there. So they are already moving. So they don't align with the align under the strong electromagnetic field. So they always gave signal void in both the films, T1 film as well as T2 films. So something which appears black in both of them is what? It is moving blood. So if you want to delineate blood vessels, what do you have to do? What do you have to do? You have to give contrast. At the moment you give gadolinium, then that structure, yeah, correct. So this Dr. RR is there. He gave the answer. So you give contrast. So whenever you want to do some angiography or you want to see some structure which has a movement inside the lumen, then you have to do contrast enhanced MRI. Okay. So T1 and T2 fat as I said. Coming to common application, I think this, sir, I think Biswas sir is saying something. Biswas sir? Okay. So we will come to now. So far, we tried to understand what are the basic terminologies, how we interpret. I know all of you must be knowing all these things, but sometimes if it is asked, question is asked to us, we are not able to connect the dots and we are not able to answer in the examination. That is why I covered all these terminologies in very basic, simple language. Now coming to ultrasound, most common application, as we all know, is assessment of hydronephrosis. Here I would like to ask you, what is the best way to measure the APD? We all know what is APD. I'm not going to talk about it. We all know classification of hydronephrosis. How do you measure the APD? What is the site of measurement of APD? Can anyone tell? Can anyone tell? At isthmus. What is isthmus? Hilum. Someone is saying hilum. So hilum. So you see this first picture, you will understand more or less you are correct. So this is the sinus. So okay, this is the renal sinus, the junction of the pelvis and the kidney. This is the site where you should measure the APD. So there are the three criteria for measuring the APD. One, the section should be a transverse section. It should be a transverse plane. This is a very commonly asked question in exam by the examiner, especially if he is like keen in pediatric urology, he will ask this question. So it should be a transverse plane. Second, you should mark the edge of the renal parenchyma, This is the edge of the renal parenchyma. And here you should measure. And third, it should be maximum dimension. So like you scan transverse up, below upward or above downward, and the site where there is maximum dimension, that is APD. So these are the three important criteria of measurement of APD. Now I will run this video. I think there is a video here. Why it is not? Okay, you see this video and identify the disease. It's a reiteration of a CT scan taken during angiographic phase. I mean, arterial phase of the CT scan. So you can see one structure which is marked with this arrow. Can anyone tell? It is PUJ, of course. Viral, it is PUJ. But what is the cause of PUJ? It is telling the cause of the PUJ.
Crossing vessels.
Crossing vessel. Yeah, very good. So if you see, the crossing vessel is one difficult entity usually we see by late childhood or by early adolescence. And most often it is a surprise to us during the surgery. But still, a good radiologist can diagnose a crossing vessel. As you can see, this vessel is crossing the PUJ. So if you see this video, then again now try to interpret. So there is a vessel running below the PUJ, this first arrow. I have given a pause there, okay? And then in the sequential film, you will see that vessel is crossing, going to the lower pole. So it's a lower polar vessel. We all know aberrant vessel is a lower polar vessel. So you, with a good CT scan, nicely conducted, which is done in all phases, because now you want to see the artery. So it has to be arterial phase. Also, you can at times see that crossing vessel if you have a good sonologist with you by ultrasound or Doppler also. Coming to one, a few people I believe in this, few people don't believe. It's called as resistive index. So we all know what is resistive index. There's a formula for that. That is called as peak systolic velocity minus end diastolic velocity upon peak systolic velocity, which is measured where it is measured at arcuate or interlobar artery. Okay. So here the normal range is 0.5 to 0.7. So it is said that if whenever there is obstruction in renal system, so RI increases. So high RI more than 0.7 to 0.8 is associated with poor prognosis or maybe has some relation with the future need of surgery. But there is no definite evidence which suggests that the high RI is associated with decision of doing the surgery. So how do we use resistive index? We use it for follow-up. Follow-up, it is a very good tool and it reflects vascular compliance, but of course, it doesn't reflect the function of the kidney. Someone told retrocaval ureter for, I think, previous one. No, it was not retrocaval. In retrocaval ureter, what you will see? You will see this type of sign. So the ureter will, the PUJ ureter will come like this, and then it will go up, and then ureter will get medialized, and over it there will be inferior vena cava. So there is a kink. Of course, there is a kink, but there is hairpin bend in the ureter. I have that retrocaval X-ray also, but I didn't keep in the slide. Coming to this picture, everyone knows this is, answer is also written. So, but it is like how you describe in the exam. So you see multiple anechoic spaces in the kidney, which are not communicating with each other. So whenever you see multiple anechoic spaces in the kidney not communicating with each other, then most likely diagnosis is multicystic dysplastic kidney. And most common cause for this is PUJ atresia. Okay, so it's not PUJ obstruction, which is partial and which is dynamic obstruction. So it is multicystic dysplastic kidney, which is confirmed by isotope scan. So if there is no function on isotope scan and there is multiple cysts which are not communicating with each other, then we make a diagnosis of multicystic dysplastic kidney. Now, can anyone tell what is this? First image and then second image. What is first image? Ultrasound picture of kidney. It's left kidney. Can anyone tell? So you can see a dilated urine field structure here, but it is not extending. So it's a duplex system. Why do you say it is a duplex system? It's a duplex system, correct. But it is incomplete diagnosis. It is duplex, correct. Would you like to add something else to the diagnosis? There is one more pathology here. What about upper moiety? It is normal or abnormal? How can you tell non-functioning or functioning on ultrasound? You cannot. Upper moiety is normal here. It is not abnormal. Upper pole is well built. Like you can see the bulge of the upper pole. It is not hypoplastic, dysplastic, which will appear cystic, multicystic. Yes. Dr. R.R. identified that there is hydronephrosis of the lower moiety. So that is a lower moiety PUJ obstruction. Now the same patient, you can see the CT image. Okay. So there is a PUJ obstruction of the lower moiety and upper moiety is absolutely normal and it is functioning also on CT scan. On CT scan, you can see the function. So it is a left-sided duplex system with upper moiety normal and lower moiety hydronephrosis because of PUJ obstruction. So this sign is known as parenchymal cleft sign because the upper moiety is bulges beyond the domain of the kidney and it gives a cleft sort of appearance, especially when there is hydronephrosis in the lower moiety. So this is known as parenchymal cleft sign. Coming to this, what is this sign? Has anyone heard about this sign? First film. So this is a CT scan. So normally, whenever you do CT scan, you see CM differentiation. That is called as corticomedullary differentiation. But in duplex, what happens? The point where there is fusion of the two moiety. So there will be no CM differentiation. That is called as lack of CMD at the middle, which is called as faceless kidney. So this is known as faceless kidney sign. And this we all know. Other one. Okay, it is drooping lily sign. So can anyone tell when does drooping lily sign happens? Say, when I was postgraduate, my boss taught me always count the calyces in the IVU, MCU, anything, whenever you see IVU, MCU, always count the calyces. There should be 3 major calyces. And the distance between the 3 calyces should be equidistant, like this. If it is like this, then it goes in favor of a duplex. So duplex moiety has drooping lily sign, correct? But when does it happen? Does it happen in every duplex? No, not in reflux nephropathy. Lower moiety ureter compression by upper moiety. No, it is not like that. So Dr. RR gave the right answer. May I know your full name, Dr. RR? Duplex with upper moiety hydronephrosis. Whenever there is upper moiety either ectopic or it is ureterocele, then that will result in hydronephrosis. Renuka. Okay. So Renuka gave the right answer. So there is hydronephrosis of the upper moiety. Unfortunately, that is not functioning. So you did not see on a IVU that enhancement is not there. So it's most likely non-functioning upper cystic upper moiety is there because of maybe ureterocele or ectopic ureter or whatever. So that results in drooping lily sign. Okay. Now, can anyone tell what is this? It's already written over there, but what is the importance? It's known as ureteric jet.
Ureterocele.
Ureterocele. Okay. So there is something called as ureteric jet. So it is very rarely you can see the ureteric jet. And ureteric jet is a ureteric jet is a phenomena which happens whenever there is a narrow opening or obstruction. So as we all know, ureterocele has a narrow opening and you can see anechoic bulge inside the bladder and dilated ureter. This is dilated ureter and you can see the cystic bulge inside the bladder and through which you can see the ureteric jet. So this is a typical case of ureterocele. Now quickly interpret all these x-rays. There are multiple x-rays. One is this ultrasound, which shows characteristic ureterocele. Okay, a cystic structure inside the bladder lined by echogenic wall and anechoic inside it. Okay. Now you see this X-ray, second one. So this one is bilateral ureterocele with duplex moiety is very correct. You can see 2 moieties. As I told, there are 3 calyces, but 2 calyces are down, 1 calyce is up. So you can see the distance between the 2 calyces. It is wide. Normally it should be like this. So this is a duplex. Okay. And you can see 2 ureters also. And this X-ray shows very good crossing of the ureter at 2 levels. We all know the ureter cross at this level. 2 ureters cross with each other at this level and at this level. There are 2 levels at which ureters cross. And what is the difference between this X-ray and this X-ray? This is cobra head sign is wrong. This is wrongly written here by me. What is the difference between this X-ray and this X-ray? Can anyone tell? That is okay कि ये unilateral है, ये bilateral है. But that difference I don't want to. Partial filling MCU.
Sir, one is at, I think, filling phase and one is violet voiding phase. I think so.
That is not the point which I want to make here. Look at the ureterocele. What is filling the ureterocele? Look at that. What is filling the ureterocele in first X-ray and what is filling here? Here you don't see contrast inside the ureterocele. Can you see? While here you see contrast inside the ureterocele. Agree with me or no?
Yes, sir.
Okay. So this is a functioning moiety. So as we can see, it is functioning here. So contrast will fill inside the ureterocele. Then the ureterocele wall will come, which will appear as radiolucent, and then the contrast in the bladder. So this is typically known as cobra head sign. This is not cobra head sign. This is just a negative filling defect inside the bladder. Yeah, that difference is there, that this may be, no, this is both are IVU. Both are IVU. It's not MCU or IVU. So difference is, this is not a functioning ureterocele. I mean functioning upper moiety, while this is a functioning upper moiety. As you can see, this is functioning. While here, if you see, the calyces, 2 calyces are seen brightly. This is the lower moiety ureter, while upper is not seen. If you see this one, the other one, CT scan, interpret it. It is upper moiety hydronephrosis. Okay, upper moiety hydronephrosis is there, and it is a duplex system. Lower moiety is absolutely normal. So you can see some dilated structure here, and then you can see some dilated structure here. Then you can see some dilated structure here. Then you can see some dilated tortuous ureter. So it must be some ectopic ureter or uretrocele. I don't know exactly with this one film, you cannot say, but now I will show you this video. Look at this video. So this ureter is going below and by the side of the bladder, below the bladder neck. So in uretrocele, it will never go below the bladder neck. Now what is the diagnosis? Tell me. So it is going, upper moiety ureter is dilated. It is going below the bladder neck, below and behind the bladder neck. So it is an ectopic ureter. Okay, very good. Dev Prabha, ectopic ureter. Okay, so this is how, see, minutely if you examine, if you know, if you have theoretical knowledge, if you have concepts of radiology or imaging, and if you have a habit of analyzing the X-ray very minutely, you can make good diagnosis. In urology, it is very important to interpret imaging. Now coming to this MRI. So we all know that we do a lot of MRI for duplex anomalies because it delineates the anatomy very well. So you can see this. So this is what first one is T2 weighted image. Okay. So now it is T2 weighted. Why I say it is contrast? Because you can see lower moiety also enhancing. So normally like a collapse system will not give you like this white shadow, hyperintense shadow unless it is dilated. You won't be able to see the normal structures. So this you can see there is upper moiety hydronephrosis, and if you look at this reconstruction, this ureter is tortuous here, having a lot of tortuosity. It is running by the side of the bladder, behind the bladder, below the bladder neck. So it's an ectopic ureter. It must be opening. If it's a male child, upper moiety ectopic ureter. Very good. So it will be either opening in the urethra in a male child, which is less common. Most commonly, it is a female child opening into the vagina. And always remember, any ectopic opening in the body is always stenotic. Any ectopic opening, you see from head to toe, any ectopic opening is always stenotic. It is never normal in caliber. So again, I reiterate, T1 is fat happy and T2 is water happy. Now, can anyone diagnose what is this? What is this? And what is the key point, key message which I want to give? What is this X-ray? So it is a duplex, correct? It's a duplex, very clear cut. Now move forward. What type of duplex? It is complete or incomplete duplex? Raj said duplex, fine, correct. It is complete or incomplete? It is partial, incomplete. Many people said it is a, what is common sheath? There is nothing called as common sheath. Common sheath is a different term. Incomplete. Everyone knows it is an incomplete duplex because you can see the junction here. So it's a partial duplication. What phenomena we are afraid of in a partial duplex system, which can result into symptoms into the child? Yo-yo reflux. Very good. So how do you diagnose yo-yo reflux? How do you diagnose? It is a dynamic process, no? How do you diagnose it? This is how you diagnose. So there is a one key word here. Can you see post-micturition here? So whenever you get a post-micturition film and you can see contrast in both the ureters, it is yo-yo reflux. Very simple. That means reflux is happening here and here and here and here like yo-yo. So post-micturiation film, if it shows both system, then it is yo-yo reflux. Fine. I hope it is very clear to you. See, I am not a very complicated examiner. I always tell things in very simple language. I'm sure everyone must be able to understand what I am saying. So I talk in students' language because I understand that way. So I will not talk a lot of technical jargons. I will talk in very simple language. Now coming to this CT scan. Okay. So you see the upper row of the images first. Okay. Upper row first. So there are three phases of the CT scan. We should make a habit of reading the phases of the CT scan. The first stage is known as corticomedullary phase. Second stage is known as nephrogram phase. and third is known as post-contrast drainage phase. Okay, so if you see the first phase, that is corticomedullary phase, here you should be able to appreciate the corticomedullary differentiation. Like I said, in duplex, you see a faceless kidney. Their CM differentiation is not there at the junction where upper lower moiety are meeting. So here you should be able to see the CM differentiation. While in nephrogram phase, whole kidney becomes white. So this is useless image to see the kidney. Okay. Now third is the drainage phase. So now what? Now you see these three films in the lower row. Now try to interpret. First one correlate with the importance of the first phase, corticomedullary phase. So whenever there is an enhancing lesion inside the kidney, a tumor which enhances, like a Wilms tumor or any other tumor, that you would like to see in which phase? You would like to see in corticomedullary phase. There you will see corticomedullary distortion of the kidney and the tumor tissue, which is slightly enhancing. While if you want to see some lesion which doesn't enhance, like for example, angiomyolipoma, rare tumor, but I've seen 2 angiomyolipoma in my life. So angiomyolipoma is a non-enhancing lesion. So that you would like to see in which phase? Nephrogram phase, where whole of the kidney has enhanced well. So you don't want to confuse your angiomyolipoma with the medulla of the kidney. Okay, right? So this is the importance of looking at the various phases of the kidney enhancement. The third is the post-contrast phase. So like if there is obstruction or calcification, like if you want to see hydronephrosis, retention of contrast is there or not, and if you want to see the calcification. So when will you see? You will see in the post-contrast phase or pre-contrast phase, that is before giving the contrast. Otherwise, the contrast will confuse that stone with the contrast. So you have to either see it in the plain film or you have to see after contrast has passed out. Okay. Coming to, so the message which I want to give here is look for all phases, assess the cortical enhancement, which is relating well with the function of the kidney. Always see timing of excretion. Like in these two images, if you see, the right kidney is enhancing well, good CM differentiation is there. Left kidney has not enhanced. There is hydronephrosis here. While if you see the excretion phase of the right kidney, so right kidney has started excreting, pelvis is seen, while left kidney has developed some enhancement. So this is a delayed enhancement in the left kidney. I know isotope scan is better investigation, but very often our pediatricians, they do CT scan, they send the child to you. So you should be able to interpret these things. So delayed excretion and retention of the contrast. While here on the right side, it is already cleared. Okay. So now coming to one word about like stone. What is the utility of imaging or CT scan in stone? In ultrasound, we all know, but in X-ray, can anyone tell what are various non-radio opaque stones? Can anyone tell? What are non-radio opaque stones? It's there in the table. So there are 3 stones which are radio opaque. One is calcium oxalate, calcium phosphate, true white stone, that is magnesium ammonium phosphate most commonly. So these are the 3 stones which are radio opaque, while uric acid stone, xanthine stone, rightly said by you people, cystine stone, and all these stones are non-radio opaque. So how do you differentiate between them? So on X-ray, they won't be visible. So CT plays an important role in understanding the stone. I will tell you why it is important to understand the density of the stone. So what is density? How do you measure density in CT scan? By Hounsfield unit. We all know the minimum HU which is possible is of air, which is -1000, and maximum HU which is possible is of bone, which is more than 1000. Or everything else falls in between these two. Okay, for a duplex moiety, which is ideal? CT IVP or MR urogram? Have seen many serials. So for duplex moiety, we always do MR. In children, always remember, CT should always be reserved. We should not do CT scan very commonly. I'll tell you later why CT is not a good investigation for children. So MR urography is the best investigation for all anatomical abnormalities of the urinary tract, provided you give contrast also. So coming to this thing back to my area of interest here in this slide, and that is, why do we want to know the density of the stone? So now you can see your radiologist or your imaging specialist is going to mark the HU of the stone. If he or she doesn't mark, then you have to ask what is the HU. Why it is important to know the HU of the stone? Can anyone tell? Can anyone tell what is the importance of knowing the HU of the stone? Differentiate from clot? Yes, maybe. Yeah. So Dr. M said to me, for ESWL, hardness, easily breakable or not. Is it useful for deciding like a mode of energy during URS or like PCNL? Like you want to use laser or lithotripsy, hydraulic? No, not really. Okay. Because with hydraulic or this thing, you can break any stone. But for ESWL, you need to know HU. Can anyone tell me what is the best HU? I mean, if you have a small renal stone, you want to do ESWL, what should be the maximum HU allowed so that you can move on with ESWL? 2000 is very high. Yeah, ESWL versus PCNL. So how will you know that this stone will break with ESWL? So this is the data. Okay. If you see this forest plot, then you can see 800 after, like, this is a meta-analysis which shows that 800 is the maximum HU, where you have maximum success rate. The cutoff value decided that above 800, the failure rate will be high. Still, you can do it, you can break. Then will be a lot of stress phenomena and a lot of problems to the child. You may have to deliver higher energy, which may cause more harm than benefit, may result in damage to adjacent structure, diaphragm, pancreas, and so many other things. So 800 HU, 400 to 600 is pretty good. I mean, a very good result you will have. But the best meta-analysis shows it is 800 HU. Okay. I think this information was important to you. Now, can anyone tell what is this? What is this sign and what is this? When is this seen? Dev Prabha told me that Padma Priya told me that there is no time limit. So I will continue my session till 10:15 to 10:30. Is that okay to all of you, or you want me to finish by 10 p.m.?
Yes, sir. Sure, sir.
Continue?
Sure, sir.
Okay. So this is, what is this sign? Can anyone tell? Continue. Okay. Thank you very much. What is this sign? Has anyone seen this sign before? I saw 2-3 times. My wife is sonologist, so I see all these things very often. No. So this is known as comet tail sign. Okay. It's a twinkle artifact appearance, which is seen when there is a ureteric stone. So red blue flicker behind the stone on color Doppler. So whenever there is small ureteric stone, you may not see that stone. You may not appreciate that stone very nicely, but you can see this sign. So always put Doppler at UV junction, try to see ureteric jet, and try to see this sign in a case of renal or ureteric colic. So cause is scanner noise and rough surface. So it is very sensitive for small stones. But obviously, ultrasound has a very high false positive or false negative rate, both. Okay. So this is something interesting which I found, so I have put it here. Now see these X-rays. See the ultrasound, sorry. The top row. So you can see one dilated structure behind the bladder. It's a pelvic examination of the ultrasound. So you can see this bladder is there, and there is one dilated structure behind the bladder. And there is a circular structure on transverse section behind the bladder. So what is this? Any guess? Mega ureter, diverticulum, extravesical ureterocele, many possibilities. But if you see, this is gradual narrowing, tapering. Can you see tapering? Some people call it red tail sign. You will see that more clearly in the next image. Okay. So, but these ureters, especially they are ectopic, not ectopic, but they are medially placed. So we all know a laterally placed ureter is refluxing and medially placed ureter are stenotic. So we all know this concept. Okay. So obstructed megaureter, primary obstructive megaureter. So this is a congenital megaureter which is having a tapering here. And then you can see it runs behind the bladder also because it is slightly medial. Okay. Still there is a possibility with these two images. I cannot be 100% sure this can be a cystic lesion between the bladder and the rectum also. I will come to that disease later on. Now look at this picture. This is very characteristic red tail sign with some indentation inside the bladder. Can you tell what is this? How many of you think it is a uretrocele? How many of you think it is a uretrocele? So there is a megaureter, there is a red tail sign, but there is some indentation inside the bladder. This patient I recently saw. So this looks like uretrocele, but the difference between pseudo-uretrocele, I have never heard what is pseudo-uretrocele, but this is not uretrocele for sure. You know why? Because it is not bulging inside the bladder. It's just the indentation of the dilated ureter and the wall is very thick. Can you see? It is bladder wall. It is not thin wall. Uretrocele will always have a thin wall. So this is sometimes fallaciously you may diagnose it as uretrocele and you put in a cystoscope, you don't find uretrocele. You keep hunting for that. So that is why these signs are important. In this CT, you can see same primary obstructive megaureter red tail sign. And here in this image, you can see very good red tail sign. Okay, it's primary obstructive megaureter. And look at this video. This is again of one of the megaureter. So you can see this ureter is going down here, dilated, tortuous, severely dilated, going behind the bladder and going and ending right at near the bladder neck. So it is like more medial. I said no, it is always little more medial. When you do surgery also for obstructive megaureter, you keep on dissecting till you get the narrow portion. It is more medially placed. Always it is stenotic. It is stenotic because it is medially placed. Okay. Coming to next. Now this is very common condition, bread and butter of pediatric urologist and pediatric surgeon. We all know this is not called as keyhole sign. And now there are various types of pattern you can see in posterolateral valve in your whole life. I have seen n number of patterns of posterolateral valve. So I basically summarized the signs of the posterolateral valve. It is not written in any book. So I summarize as direct signs and indirect signs. So what are direct signs? If you see valve with negative shadow, like in this film you can see a dilated posterior urethra, of course, elongated posterior urethra, like in this film you see elongated posterior urethra. And fourth, keyhole sign on ultrasound. Keyhole sign, negative shadow of the valve, type 1 valve, then elongated urethra. So these are characteristic signs or direct signs of posterior valve. Then there are certain indirect signs. So whenever you find crenulated bladder, always hunt for the valve. Sometimes maculating film is not great, oblique film is not taken. So many problems are there. So always have a suspicion. Hypertrophied bladder neck. Next important thing is having a hypertrophied bladder neck. Like in this picture, you see what is hypertrophied bladder neck? You can see acute angle here. Acute angle. Okay. So this is known as hypertrophied bladder neck. And if you have done cystoscopy of these posterior valves, especially those who have hypertrophied bladder neck, then it's very difficult to negotiate from dilated posterior urethra. Then you have to just bend down and then go into the bladder. That bladder neck comes on your way on the scope because it is so hypertrophied. So another indirect sign is reflux in the ejaculatory duct, like you see in this X-ray. Okay, there is reflux in the ejaculatory ducts. Reflux will never happen unless there is distal obstruction. So it may be seen in meatal stenosis because of phimosis. It may be seen after post-hypospadias stricture. It may be seen in posterior valve, and that results in recurrent epididymoorchitis. So many a times we see patient comes with recurrent epididymoorchitis. Always suspect a lower urinary tract obstruction. Of course, VUR, and there is something called as Cobb's collar or type 3 valve. Okay. Now, can anyone tell what is this first image all about? I don't use it, but I read a lot about it. I don't use it in my practice. What is this first image? EAR. I don't know the short form. Urethral ratio. Posterior urethra to anterior urethra ratio, right? Posterior urethra to anterior urethra ratio. And what is the value? Like, it is useful for post-fulguration assessment that your ablation is adequate or not. I prefer a Czechoscopy, 2.5. Fine. Now, what is the second image? What is the second image? Anyone? What is the second image? Can anyone tell? So it is a type 3 valve. Okay. So in your clinical practice, maybe like out of 20 patients, you can see once upon a time, you can see type 3 valves also, usually seen in bigger children. Copum. Yeah. Copum. Congenital obstructive posterior urethral membrane. Described by, okay, fine. So this is also a type of valve. Few people say it is not a valve. Few people say it is a valve. Or few people say type 1 valve is nothing. It is copum only. So all that debate goes on. But you should be able to identify the valve. No, it is not young. Copum is not young. Young is type 1, 2, 3. What is copum? Who described copum? Okay, leave it there. So Devans, it is Devans classification. Okay, it is Devan. Yeah, right. Ankita said. So now coming to one more important sign. Nowadays, you guys must not be finding this sign, but I see quite often in my area, and that is urinoma formation, extravasation of the contrast from the kidney because of like sort of pop-off mechanism, which has a controversial role to play nowadays. But there's sometimes exudation of the contrast into by the side of the kidney. If you see this video, there is a video here. So you see this. So there is hydronephrosis and there is collection of the contrast outside the kidney, And that is known as, nowadays you don't see, but we used to see it very often. So I have included it. That is called as C sign or P sign. Okay. C sign means crescentic contrast on the surface of the kidney. And sometimes that contrast trickles down by the side of the ureter. That is known as P sign. Now, we all know there are two conditions. One is antiurethral valve, another is antiurethral diverticula. And it is at times very difficult to differentiate which one is. One second, this chat box I have kept open, so it disturbs me. Sunburst appearance. Sunburst appearance for what? Sorry, sunburst appearance for what? I am not aware about that. Can Dr. iPhone please clarify? Open your mic and please clarify. I am not aware of this sunburst appearance. Please, I will be very happy to know about it. Dr. iPhone, please. बता दो यार, शर्माओ नहीं, मैं तो नहीं शर्मा रहा, इतनी देर से बोल रहा हूँ. It is seen in intrarenal reflux. Okay, fine, I'll read about it. So now, how many of you know how to differentiate between anterurethral diverticulum and anterurethral valve? Is there anyone who knows? I'll show you the image. Miglani sir, thank you. Thank you very much. So, this is the picture, you see. Very good, Dr. Nell. So, angle between what? Angle between what? Between the diverticulum or whatever bulbous swelling you see and the urethra. If it is obtuse, then it is valve. And if it is acute, it is diverticulum. Why it is important to differentiate between the two? Because the treatment of anterurethral valve is incision. You have to incise it here. Okay, while the treatment of diverticulum is what? It's a congenital urethral diverticulum. So there is spongiosal defect. So you have to repair it surgically. Okay, so that is the importance. Now, can anyone tell what is this? What is this? Very simple. Diverticulum, yes. Which one is diverticulum? Which one is bladder? This is bladder or this is diverticulum? The arrow which I am pointing here, laser pointer is there. It is diverticulum. Why? Why this is diverticulum and this is bladder? You are right. Smooth walled is always diverticulum. Very good. Because it is not a true diverticulum. It is a secondary diverticulum. It's a false diverticulum. It's not a true diverticulum. Sometimes you get congenital true diverticulum where all the layers of the bladder wall is there in the diverticular wall. I've seen those cases also. So they're sort of like duplicated bladder. So that will have irregular margin as well. While a secondary diverticulum like Hutch's diverticulum will have a smooth wall and the ureter will be draining sometimes into the diverticulum only, or maybe by the side of the diverticulum. As you can see, same patient, the ureter is opening in the diverticulum, it is behind the bladder, bladder is appearing crenated. Why crenated? Why crenated? Because there is recurrent infection and these diverticulum tend to compress the trigone and the bladder neck. When they distend with urination, they compress the bladder neck. So usually children will present, huge diverticulum, children will present with obstructive uropathy and LUTS, symptoms of lower urinary tract infection, obstruction. Another case, okay, I'll leave that. Now, can anyone tell what is this first image? There are a few more slides, maybe four or five slides more. What is this? This is bladder you see, this is the urethra you see, and then you see a structure labeled as C and another structure labeled as S. So ureter is opening into something where it should not open. It should have opened here, no, in the bladder. So it is not opening there. It's opening into the seminal vesicle, and it is causing seminal vesicle cyst. So what is this? What is this disease? What is this disease called as? Anyone? कोई तो पक्का बोलेगा, मुझे पता है. I'm sure someone will come out with the answer. Any syndrome? Zener syndrome. So what are the three components of Zener syndrome? No, this is not Zener syndrome. This is just seminal vesicle cyst with ectopic ureter in the seminal vesicle cyst. I knew you will say Zener syndrome. It is not Zener. Zener has three criteria. One, ipsilateral renal agenesis. Two, ipsilateral seminal vesicle cyst. Three, obstructed ejaculatory duct. Three things have to be there. I'll repeat. First, ipsilateral renal agenesis. Second, ipsilateral seminal vesicle cyst. And third, ejaculatory duct stenosis. So here, neither ejaculatory duct stenosis is there. This ureter is seen. This is not renal agenesis. It is not Zener. It is ectopic ureter into seminal vesicle cyst. While if you see this picture, this is another patient. You can see a midline cyst. As I spoke before also, if you have cystic lesion behind the bladder, then what is the most common diagnosis? What is the most common diagnosis? You see very often, but you treat very rarely. Seldom you treat, seldom you do surgery for that. Very often you see that. What is that? Once in a while you will see that in hypospadias while you catheterize the patient. Now I've given the full hint. Anyone? Prostatic utricle cyst. So this was a large prostatic utricle cyst. You can see it was behind the bladder, causing the bladder neck obstruction and recurrent infection, hydrouretronephrosis. This patient had ipsilateral ectopic kidney, which was ureter, refluxing ureter, and the kidney was dysplastic. So we did a laparoscopic excision of the kidney, cyst, everything, and patient did well. So this is rarely you find a case for prostatic utricle cyst undergoing surgery. This is one of them. We have published this in Journal of Indian Association also. And this we did 3D laparoscopic. Beautiful thing, doing surgery by 3D, like robotic. Now, this is VUR. VUR is like an enigma. There are 100 things I can teach about VUR, how to look, what is voiding film, what is excretory film. But there are few points I would like to tell. Which reflux is more dangerous, during voiding or during filling? Anyone? Which reflux is more dangerous, more harmful to the patient, voiding or filling? Filling, because it is happening more frequently. Okay, so the first thing, dangerous, right? So first thing you should see in reflux is, obviously we look for the grade of the reflux, grade 1 to 5. So which has more importance in clinical practice, grade of the reflux or mechanism of the reflux? So there was an era when we were taught grade was the most important thing determining the prognosis. But nowadays, it is not the grade only thing. It is about mechanics of the bladder. When is that happening? So a filling reflux happens more commonly. Even a grade 1 reflux can cause more scarring as compared to grade 5 reflux happening during voiding phase. So you have to look at the all phases and post void film, how much evacuation is happening, how much drainage of the ureter is happening. I won't go into detail of the VUR. You can cover one session completely like on VUR only. Now coming to this, what is this? Can anyone describe the first image? First image, what is this sign? After class is over, can you please explain previous X-ray of seminal cyst? Why not now? Okay, fine. So this is the ureter and it is opening into a cystic structure which is seminal vesicle, and seminal vesicle through ejaculated duct is opening into posterior urethra. So it is a case of ectopic ureter opening into the seminal vesicle cyst, secondarily causing seminal vesicle cyst, and ejaculated duct is there, which is not stenotic. So it is not Jenner syndrome. In Jenner syndrome, ipsilateral renal agenesis will be there, ipsilateral seminal vesicle cyst will be there, and ejaculatory duct will be stenotic. Okay, so this is spinning top appearance. It is characteristic of neurogenic bladder. Okay, so this usually seen in female children. Okay, spinning top appearance, and this pattern is called as what? This bladder is called as, everyone knows, Mickey Mouse bladder, Christmas tree. So many words are there. And what about this ureter? This is called as corkscrew ureter, which is very commonly seen in neurogenic bladder. I don't know the reason why it is seen, but it is very well described. So what you see in neurogenic bladder: trabeculated bladder, diverticular outpouching, Christmas tree or pine tree appearance, pine cone appearance, this spinning top appearance. Bladder neck is open, like you see in this patient. Bladder neck is wide open. It is not hypertrophied, wide open. Sawtooth ureter or corkscrew ureter, okay, and funneling neck. So these are the various signs you see in neurogenic bladder. More important investigation in neurogenic bladder is, I think, UDS. So we will not go into much detail here. Now, some interesting thing coming up. Can anyone tell what is this disease? Okay. So this patient is an infant having a normal urinary meatus here, and there is one opening on the ventral aspect in the perineal region. Yes, it is duplication, but be more elaborate. I mean, tell what duplication it is. Is there some associated abnormality? Fmen 2A2, right? It's correct. Anything else? So I could put feeding tube through which urethra, which is more likely? Through this urethra, feeding tube will go easily, or through this urethra? Through which urethra? A or B? Through perineal. No, never dorsal, because as a rule, in duplication, ventral urethra is more patent. Dorsal is usually hypoplastic or atretic. Okay, so this is catheter is going through this, and now look at this MCU. You can see duplication here. Okay, two urethras seen. Dorsal one is narrow. Can you see it is narrow till this point? And ventral is patent. But what is this? What is this? Dilated, elongated, posterior urethra. Finish. Direct signs. Dilated, elongated, posterior urethra. Direct sign of what? Direct sign of what? Posterior urethral valve. So it's a urethral duplication with posterior urethral valve. Very good. So it's so easy, na? If we remember, dilated, elongated, Professor Burvankar taught me. Dilated, elongated, posterior urethra, nothing else, posterior urethral valve. So it is so easy to diagnose. That's how we diagnosed it. So it was a rare case of urethral duplication with dilated with posterior urethral valve, obviously. And what is unusual in this patient? Unusual in this patient is dorsal is also patent, but it is narrow. It is narrow. It is not allowing scope to go here. So the scope is going till here, but after this scope is not going. So we had to do scopy through this to ablate the valve and remove this portion and reconstruct the urethra distally. This case you will find in the textbook of IAPS or pediatric surgery. I have put there how we managed it. Okay. Now look at this. So there are two openings. One is here another is here. There are two streams. Can you see? There are two streams. One is here. Both are good. Both are good. What is this? This again duplication. So I always say pediatric urology, it is physics, it is mathematics, it is philosophy, it is physiology. So it is like mathematics. Okay. So bladder diverticulum is a secondary thing which is happening in this child. So you can see dorsal is atretic. So as a rule in urethral duplication, dorsal is hypoplastic or atretic. So in this child, it is not atretic, it is hypoplastic. But child is passing urine through two streams. What will you do for this child? What will you do? What will you do?
Urethrostomy can be one option.
अजी बेटा
Urethrostomy can be one option.
अभी तो ये इतने अच्छे से यूरिन कर रहा है दोनों से. You want to make him pass from the under surface? No. Close the dorsal urethra. Keep ventral urethra as it is. Ventral is little hypospadic, but
सर दोनों को एक बना के urethrostomy नहीं कर सकते.
so that is the solution because both urethra are patent. Why
We
you
can
want
do a
to do
single
it?
channel urethrostomy.
That is called as common
Common
channelization.
channel urethra. Yes, sir.
You need not do it throughout its whole length. It's
Yes,
just
sir.
cosmetic correction, basically.
Cosmetic correction. Yes.
Okay, because child is not having problem, but this child does have a diverticulum. Okay, so but we are following this child. This diverticulum is reducing in size, so we have not intervened it so far. Okay, very good. This is another duplication case where dorsal urethra is totally normal, but there is a perineal Y-type duplication. Y-type duplication is there. But this is unusual. See, I said, na, as a rule, defining surgical anatomy, classifying the duplication is a difficult thing. So you have to identify the patent urethra and accordingly you have to plan the reconstruction. As a general principle, ventrally located urethra is more normal urethra and is likely to be retained by us. While in this patient, if you see, ventrally located urethra is hypoplastic. So there is always exception in pediatric urology. So you cannot go by mathematical rules, but the rules are good to make a primary diagnosis. And most of the time you are correct. But sometimes there are exceptions also. So here what we did, it's a very simple operation. What we did is we just excised this portion from the perineum, laddu operation, nothing. No complex surgery required. Okay. Now, coming to the end of my lecture. So we all know about LRA. It is as low as reasonably achievable. We should give minimum radiation to our children. Best investigation is ultrasound. Second best investigation is MRI. You should always avoid CT scan. And whenever you do CT scan, you ask for specific things. There should be specific reason why you want to do CT scan. And this thing is theoretically very important. If you see the textbook chapter of radiology in IAPS textbook, I put this table. So we should all know nowadays we measure radiation in the form of which unit? Sieverts. Okay. We don't call Curie like in our days Gray or Curie and all these things we used to say. Now we call it Sievert. So what is the normal effective, dose in chest X-ray? It is 0.02 Sievert. Okay. While in a chest CT scan, it is 8 Sievert, which is how much? 400 times of a chest X-ray. 400 times. An abdomen CT scan, 500 times of the chest X-ray, one chest X-ray, which is equivalent to what we have some radiation around us also. So nowadays we always take this radiation around us as a reference. So chest X-ray is equivalent to 2.4 days of radiation which we are having around us. I'm not talking about Delhi people, but I'm talking about people living on an average. The radiation is 2.4 days radiation. While if you do a chest CT scan, it is about 2.7 years of radiation in one go. So one should carefully use CT scan. So there is another figure which I want to convey to you. As a rule of thumb, lifetime cancer mortality risk attributable to the radiation exposure from a single abdominal CT examination in a 1-year-old child is order of 1 in a 1,000. So there is risk of like 1%, one child developing cancer out of 1,000. So we should always replace with ultrasound or MRI, and multi-detector CT reduces the exposure time. Nowadays, low dose CT is also coming available. I included that in my slide. I did not tell about it because it is not commonly used. We should use thicker sections. We have a habit of writing HRCT. Never write HRCT. Always write. You should focus your questions to the radiologist that I would just want to see this. So give minimum radiation, and computerized reconstruction from thicker sections solve the purpose. Nowadays AI is coming, so it is becoming more easy. As you can see, this slides I will share with you. It will be useful for you in examination, theory examination. So natural background radiation is about this. Okay. And MCU gives very less radiation because you just see one filling and one voiding phase, while IVU is less than natural background radiation. So IVU got a disrepute that why radiate, and CT emerged. So people are like doing CT scan left, right, and center, but avoiding IVU. I do more IVU than CT scan. IVUs are more useful than CT scan in pediatric urology, but many may differ with me also. Retrograde pylography, like you can see the comparison. And what is worst? CT urography, which we use left, right, and center nowadays. See, we always write CT urography, CT urography. So this is very dangerous thing. You are giving a lot of radiation for CT urography. Best is MR urography. So what is the take home message today? Look at films and images, not the reports. I often see, you see the opinion. Or you first look at the films, try to identify normal structure. That's how I learned radiology during my PG days. Look at the normal structures. I have used to identify each and every normal structure, even if it is not of my interest. Second, make a habit of reading film, not like this, in the view box properly, or on the computer or console, wherever you go. Utilize ultrasound well, minimize the radiation exposure. MRI is a boon. Only problem is you have to give anesthesia and it's slightly more expensive. Anatomy follow rules, as some guy when I said that there are a lot of rules in pediatric urology. I always say pediatric urology is all about physics, mathematics. It's about physiology. Nowadays, physiology is emerging, and philosophy. So, pediatric urology is a philosophy. So, our eye see what our mind knows. If we don't know faceless kidney, then we will not identify it. So, discuss images with radiologists. Talk with them more often. They are more beautiful than us, and they are very cool. So, you talk with them. Always visit radiology center. They are our light who let us understand these shadows. If there is any question, of course, they will upload this video. If there are any question, I will be very happy to answer. If I miss something, please point it out. In the next presentation, I'll try to include that as well. Thank you. Now, house is open for comment, questions, discussion. If any senior is sitting here, feel free, point out my mistake if I have done some mistake during my presentation. Thank you very much.
Sir, Viral here.
Bolo.
Sir, actually, what I asked, CT IVP versus MR, sir, radiologists are telling CT IVP is far better for all the things, but we are mostly suggesting MR urogram. But there are hardly some senior radiologists reporting that. Other people are suggesting CT only. And which is better, sir?
I agree with you. Nowadays, CT has become a very good quality CT scans have come. It gives very good anatomical delineation. But if my radiologist says this, I say no, I prefer MRI because I don't want to radiate my child. Suppose a girl child, there's very high chance this child can develop infertility. So we have to defend our children. Okay. So it's not just about evidence. What evidence says that CT is better, so we do CT scan, CT urography. So we have to defend our children. See, after 20 years, they will come to you with infertility. I am like having practice of 22 years. Now my children will come later on, no?
Yes, sir.
With all those problems. So, and now this is the era of medical legal, this thing also. Someday our public will get, alarmed with all this, like they can accuse doctor also that too much radiation he has given because of that infertility has happened. So be cautious. Don't just go on the evidence. Ultrasound is a very valuable tool. Use a combination of ultrasound MRI, but if required, you have to do a CT scan.
Yes, sir. Thank you, sir.
Yeah. Anyone? Anyone else? A few senior people also sitting here. If something I have left or I have given a wrong information or some additional point you want to make out, please feel free, sir and madam.
Sir,
Yeah, please.
Sir Karthik here.
Karthik, how are you? Please tell me.
Sir, yes. One observation I always wanted to tell. While doing the IVP, it was always found that the films we take could not anatomically delineate the structures we wanted to see well. And there was always the background of the
Gases.
bowel gaseous
Yeah, correct.
distension and all.
Especially
So,
if you're
is there
doing
anything?
infants.
Yes, sir. My question was, is there any tips and tricks that you can tell me uh, so that I can get a better quality image?
See, it's all about like how radiologists, because we don't perform IVU. So radiologists perform. So bowel preparation we used to give in adults, but in children we don't recommend bowel preparation. So normally what I do is like I keep my child starving for 2 hours at least. Like immediately after feeding, if you send a child for IVU, then a lot of air is there, a lot of and burping is always a problem with the mothers. So in infant, I agree with you that IVP is overshadowed by these gases and all, but you can keep like starvation of 2 hours and good burping is done before like IVU, and good hydration has to be there, because if your child is not hydrated, then excretion is not great. So these things you have to remember. You cannot like it cannot imitate a CT scan. So nowadays people are giving up on IVU. If I talk about IVU, then people don't agree with that. Very few pediatric urologists in country are doing IVU nowadays. I don't do it routinely, but there are few patients where I do IVU.
Thank you, sir. Anyone else? You feel free. You can ask me question later on also. You all have my WhatsApp number. Thank you for patient listening, and thank you for giving ample of time. See, these are like detailed x-rays and all. I need to elaborate everything. If time is less, I cannot elaborate well. I am very keen in like taking other imaging classes also. If you want, you can take on GI also, neuro also, whatever you want. Okay.
Thank you, sir. Sure, sir. We'll coordinate another session for that, sir.
Thank you. We can stop the recording now.
Yes, sir. Thank you so much, sir. It was a very enlightening session for all of us.
Thank you.
Thank you, sir. Good night, sir.
Good night.